about, Richard, would you hand me the NPA and the OP? Sir? Whenever SAM type set up, again, making sure that I have 2 blades available. Working Mac 3, working Miller 2 blade. You guys will be learning on the Macintosh blade, okay? Purpose of this blade, why we learn on it, is that this flange, you'll see, is so big. This will help. This is where the tongue's going to go. We have a lot more real estate to navigate that tongue, right? So use it. Properly styletted and checked endotracheal tube, which we have. Nice little hockey position. We check the cup. And what I do is I'll set this on a patient right there. I'll put my blade right here. And I'll also have my drugs right here. Okay? We'll just go through this the whole way. We've done all that. Good. We're going to use that in a second. I'll come over there. So when we're going to do an endotracheal intubation, first thing is making sure that we've fully denitrogenated that patient. We know that we all breathe 21% room air, and we know that if we can give ourselves 80% room air, basically 4 times the capacity in that FRC time. We know that when we have, you look at a oxyhemoglobin dissociation curve, and a FRC that has 80% oxygen in it through denitrogenation or pre-oxygenation, we know that it takes 70 kilo man roughly 8 minutes to go from a 98% SpO2 down to a 90% SpO2. So a lot of value in doing this. Don't forsake doing that. Don't ever go to sleep and push your induction drugs before you do it. I said I'm going to teach you advanced ventilation. First thing, that's driving me nuts. Not having an elbow. So advanced ventilation, C and E. Your C and E. This just holds, stabilizes that mass. Start up in the ramus of the nose and work down. You'll see me pull this, the mask seal over the corners of the mouth. This is where a lot of your leak's going to happen, right and left. So this is when I'm saying rocking back to forth, is to make sure. Now I'm not tempted, because I can see the leak right here, to push down. It's going to occlude my airway. This finger under the mandible, this pinky, angle the mandible right there, and I pull that into the mask. He's a little harder to mask ventilate. That's okay. Just practice getting it here. And then this is going to be my one-handed mask. Okay, and I can feel the leak. And so you'll rock back and forth. This is the rocking right here as I'm pulling that mask up. Okay, and you feel the leak. Just kind of rock to get it back in. I have a big leak. So as you've established your mask ventilation, and you know that you can ventilate, next thing you're going to do is give your muscle relaxant. As you're waiting and you know your muscle relaxant, say we're going to give rocuronium. This is the onset for rock. You got it in the muscle relaxant yet? No. So rocuronium, we're going to say, takes about 45 seconds to a minute to work, right, to give us those optimal intubating conditions. So I've given that. I'm going to go back and I'm going to mask ventilate for that minute. And how would I know that it's working? A couple things. I can clinically see that it does become a lot easier to ventilate. I'm going to see my tidal volumes on my mask ventilation go up from 300 to 600 because I'm relaxing all that skeletal muscle. And then once that's ready, then I'm going to intubate the patient. And I'm going to come over there to show you exactly in a second. But first thing I'm going to do is I'm going to tilt that head back a little bit more. Scissor the molars is what I'm going to do. I'm going to insert this into the right side of the mouth. Pull your fingers out. Yes?
Why right side of the mouth?
Because you're sweeping the way this flange is going to move that tongue up. This is how you're going to, there's always going to the right and moving that tongue.
Okay.
So I'm grabbing the tongue right there.
So right, a little bit to the left of that?
Right like this, and then go midline. Go midline. Mm-hmm. And in a real person's tongue, this is kind of connected down there in the mannequin, but this tongue will move all the way up. And you can see right there. Okay, so I go in and I start to walk down. I'm going to show you on that how we walk down in a second. But this isn't moving now, and I'm lifting up towards the corner. And then I can expose, and you can see right there. You can see there's the epiglottis, there's a vallecula, there's your view. You can look over my right shoulder. Where'd that shoulder?
Excuse me.
Yep.
See it.
To work out when you do this, 'cause he's hard. His tissue is not as
Plastic.
compliant.
Not compliant. Plastic is not very compliant.
So once I have the view, you want to have a view. We do not want to do blind intubation. Don't hold this up here. Just look at the movement, right? Hold this down here. Small, purposeful movement. Okay, so go in, making sure I'm not pinching any of the, I'm not going to break the teeth by moving. Not going to pinch the lip in between the blade and the teeth. Up and out. Good view. Okay, cuff just went past. Can you turn on my cylinder? Cuff just went past. Now this comes out. And let me show you this way. So you're going to have gloves. You have gloves, please. Large. You're going to have gloves when you do this. One. The mouth is filthy. It's dirty. The worst thing you... Let me have two gloves. I'm going to show you this. Now I changed my mind. Sorry. Can't make up my mind, huh? I want to show you the right way. So, my hands are in here and I've scissored and I've done all this and I come back. I don't want to do all that, right? I'm going to dirty my bag. I'm going to dirty all my knobs with this terrible breath. I've come in here and I've intubated. When this comes out, do I want to set this on the pillow or all over? This is dirty. So I'm going to do this. Put your glove over your laryngoscope. Okay, get rid of that blade. So now it's clean. Okay, before I go and grab this bag, take that glove off. Now everything's still clean, right? Stylet's off. This just prevents contamination. I hate going in to give breaks. People that I know that are dirty, because I'm touching their bag and doing, it's nasty. All this is dirty when you go in. I don't like to do all that. As not being OCD, maybe it is, but I'm still not touching everybody else's crap, right? Doing all that, come back, grab my tape. That's how you do intratracheal intubation. Pretty straightforward, okay? Make sure you use care for your dirty stuff. Now I want to show you. And you guys will probably forget to do this in your first few times, and that's okay. I'm sure you'll have a nice welcome to the anesthesia profession when you have to wipe the whole thing down with those sandy wipes or whatever they're called. So, when we come in and go, the tongue's going to come in here, or the blade's going to come in here to the tongue, and we're going to walk back to the base of the tongue. Okay, start to see the bumps on the base of the tongue. You know you're there. First thing you're going to do when you're going down is you're going to find the vallecula. You're trying, when you go down, you're walking down a little bit to identify anatomical location. So I notice this is the tongue. I know it's not the base of the tongue. What's the base of the tongue have that the other part of the tongue doesn't have? What are those called? What are these called?
Ones?
These guys, what are these called? I'm actually forgetting right now.
Papillas?
Sure. Are they tonsil papilla bumps? Okay, great. Tonsils. So you look for the tonsils on the base of the tongue. I've identified my epiglottis, right here. For the Macintosh blade, it sits right in here between the base of the tongue and the epiglottis, which is called the vallecula. This is the proper seating of the Macintosh blade. Then I'm going to lift up, and this is about the view you're going to see. You'll still see epiglottis with your Macintosh blade. Does that make sense? Now, with the Miller blade, same thing. Go in, moving that tongue. You can see just by already the difference in the flange, right? So tongue control is really important. You go down, okay, base of the tongue. I should be noticing epiglottis coming up. Yep, got epiglottis. You're not going in there. You're going to go distal, then you're going to pull up. And that's the traditional view you'll see with a Miller blade. To me, this is why I use a Miller blade, because it's a lot better view. but it's a lot harder to use this blade. Okay?
It wouldn't traumatize epiglottis if you.
No.
Okay.
No. I mean, this thing's kind of a weapon, but it doesn't. I mean, it's really, you don't. Yeah. If you're in there digging at it and stuff, probably. But that's your view that you do right there. One thing that you may see some people do later on is they'll put a Macintosh 4 blade on. It's a little bit longer. So if you ever needed to, some patients may have a very floppy epiglottis, so you're seated in the vallecula, you lift up, and this epiglottis is just hanging down. The cartilaginous skeleton's not working very well. It's old or whatever. What you can do is go distal like a Miller blade and pick that up with the Macintosh. Try not to do that when you first start. Place this where it's supposed to be placed. And that's pretty much endotracheal intubation. After that, we would connect over, confirm end-tidal CO2 placement, secure, and go from there.
Is there a special way to tape it, or just?
The endotracheal tube? Remember the split tape that we had? Just like that. Yeah.
And you always go on the right side of the tongue.
Yeah, the laryngoscope will always be in your left hand. Just doesn't go in the right hand. Always start on the right, like this, and move midline. Sometimes patients may have a small neck. Patients may have big breasts. You can't really get in the tip like this. So what you might do is come into the side like this and move midline. If you can't go down to get in. Yeah. Cool.
All right, cool.
Questions? Pretty straightforward.
That's pretty much it.
Okay. I think we have time for one more person.